Good evening. My name is Charlie Sorensen, and I'm the president of the Kittitas County League of Women Voters. On behalf of the League and the Ellensburg Public Library, which co-sponsored this program, I'd like to welcome you to this program on the state of healthcare in Kittitas County. Housekeeping details. The restrooms are that way. Before we get to the program, one of our members has donated money for a membership to someone who might not otherwise be able to afford it. So if that sounds like something you'd like to do, write your name, address, and phone on the card back there and put it in the hat. We'll draw names out of the hat and award a membership for 1 year to some lucky person. Also, if you're a fan of the League and what it does and its programs, we'd love for you to make a donation to help us underwrite the costs of those. And there's a hat in the back for donations. We acknowledge the people who have been on this land since time immemorial. Kittitas County is on the land ceded by the Peshawanappum and other bands and tribes of the Yakima Nation and the Treaty of 1855. The Yakima people remain committed stewards of this land, cherishing it and protecting it as instructed by elders through generations. We are honored and grateful to be here today on their traditional lands and give thanks to the legacy of the original people. Many thanks to Robbie Soltz, our program's chair, who could not be here tonight, but who put this program together. It's being recorded and will be shown on ECTV2, Spectrum Channel 131, and our own YouTube channel. Our discussion panel this evening includes Julie Petersen, CEO of Kittitas Valley Healthcare and Superintendent of Upper Kittitas County Medic 1. Julie has been at KVH since 2016 and has worked in community healthcare for 38 years. She is past chair of Washington State Hospital Association and the Association of Washington Public Hospital Districts. Dr. Mark Larson, Kittitas County Health Officer since 2006. In 2015, Dr. Larson was awarded the Dr. John Anderson Memorial Award for Outstanding Rural Health Practitioner, and also the award for the State Family Physician of the Year. Robin Reed, Executive Director of Kittitas Valley Health Network. Robin has a master's in community-based public health from the University of Washington, so do I, go Dogs, as well as a bachelor's degree in Spanish language. She has nearly 20 years experience working in public and community health. The format for this evening is each panel member will get up and give their talk and presentation, and then we will accept questions from the audience. In order for the video to really record well, we have to remember to speak directly into the mic. So when we open it up for Q&A, we will repeat the questions before answering. So let's get started. Let's join me in welcoming our panel. And Julie Petersen will go first.
Thank you very much. And again, I'm Julie Petersen. I'm the wordy one, so they put me first, and I promise to talk quickly. So, thank you. There we go. What am I pointing at?
Right here, warm up a month.
Oh, okay.
You don't have to put it.
Okay. All right, so again, I promise to be as brief as possible. I wanted to talk this evening, and again, I'm the CEO at Kittitas Valley Healthcare, which is a public hospital district, and in Upper County, we have a second public hospital district that operates Medic 1. So Kittitas County is wall-to-wall public hospital districts. Our governing boards are elected by the citizens of Kittitas County. I consider that a real privilege and a real plus for the citizens of Kittitas County. But my topic tonight is the healthcare workforce and the changes we're seeing. And I do want to acknowledge that that term workforce is sort of a catch-all for all the things that frustrate you in the healthcare market, in why is my doctor leaving? Why are my appointments so short? So when it's shorthand for a lot of the dynamics that we're seeing in healthcare right now. So speaking of shortages, as Charlie mentioned, I've been doing this for about 38 years, and I will tell you, 30 years ago, we knew that there were not enough slots in medical schools and to train the doctors that we would need, the nurses and the technicians that we would need. And we knew 30 years ago we weren't going to be able to replace the doctors based on the aging workforce and based on the increased population just in the country itself. And then we had baby boomers like me that we knew would be coming up through the system and requiring more and more care. And healthcare itself was becoming more complex. We rely on the very expensive and important diagnostic tools and lab tests and things, but that makes healthcare a lot more complex and it takes more time. All of that we knew 30 years ago. We should have been planning to expand the workforce, and we did not. We did do some things, and we got some things right. We rely more heavily on really good foreign-trained physicians now. And increasingly, we're seeing foreign-trained nurses and technicians that we're able to recruit in, lab techs, radiology techs, and nurses that we're able to recruit in who are just excellent additions to our workforce. The other thing that they did was increase the pipeline for what we call APCs, or advanced practice clinicians. So those are your PAs and ARNPs and CRNAs and certified nurse midwives. There didn't used to be a lot of them, but we see schools now that are graduating a really high quality and a high number of those APCs. Beyond just the shortage, though, other things were going on in the market. And around 2000, and I remember this, we began seeing a significant shift from the private partnership type markets or practices that we had to employment models. So when you think back to the healthcare landscape in Ellensburg in 2000 and up in Upper Canton, you had private partnership type practices, you had Valley Family Medicine, you had people like Elise Herman and John Sant, all those folks, they were in private practices that were based on partnership models. Over time, and beginning in about 2000, increased regulation, complexity, and administrative burden made it more and more difficult for those folks to stay in private practice. Insurance plans began contracting with this group and not that group. We had the emergence of not just the electronic health record, but electronic systems in general. So all of a sudden, rather than mailing claims to the insurance company, they had to be scrubbed and sent electronically. And one insurance company would like them one way, another insurance company would like them another way. These practices didn't have IT departments. They didn't have computer systems to do that. And there are more codes. At this point, I think there are 12,800 CPT codes and counting. And you had to get those right, and they had to be properly documented. Insurance companies started creating barriers like prior authorizations. So all of this really added to the burden of these private practices that had served communities for years. In 2022, only 26% of physicians were employed in private practice. Between 19 and 21, almost 109,000 physicians left private practice. Between 2019 and 21, 36,200 practices were absorbed into systems or into very large groups. And there are 13% fewer physicians in private practice than there were 10 years ago. 80% of them said they had to leave that model because they were not able to negotiate sustainable insurance rates. So these, besides just the shortage, you had these folks that were having to change the way they had done business for years and years. So why does it matter if they're in private practice or if they're employed? And I want to be really, really clear here. I'm not demonizing anyone, and I'm not making judgments about the current workforce. The market is the market, and I don't have the energy to argue with the market. But the fact of the matter is that these partnerships, they own their buildings. So when you hung up a shingle and you dedicated yourself to a practice, you were making a commitment to that community, to that address, and that patient population. And it contributed to the stability and the longevity. It's why you had doctors in a community for 25, 30 years. Partnership equity was a big part of their long-term retirement and long-term financial plan. So they were all about building those practices. Physicians cared for outpatients and inpatients. If you were the patient, you were the patient. Practices were responsible for covering their own patients. So if there are five partners in the practice and one of them goes on vacation, the other four pick that up. They were responsible for delivering their own babies. I think Bruce Herman delivered every baby that he ever saw. I think the same is true with John Sand. And your doctor admitted to the hospital. You got sick, your doctor saw you and said, you know what, I'd like you to go over to the hospital. He made a call to the med-surg floor. It was what we called a direct admit. And in you would go, and after clinic hours, your doctor would come over and take care of you. And in the background, doctors were organized in what were independent medical staffs. And that independent medical staff, again, they're not employed by the hospital, so there were these groups all over the community. And they came together, they elected officers and committees, and that's through that very strong independent medical staff was how they influenced management and governance in the hospital. So there was a really healthy friction between the medical staff making decisions and the governing board in these hospitals and hospital districts. Increasingly, we have employed physicians, and increasingly that is the only model that a lot of physicians have known. A lot of them have never been in partnership with private practice. And again, without judgment, those providers now, those physicians, are just as mobile as any other employee. So just like we recruit nurses and techs and housekeepers, we're competing based on base compensation, retention and production and quality bonuses. Student loan repayment is huge for our recruits now. Retirement, relocation, all those sign-ons that you hear about. But a physician can take another job out of town just as readily as a nurse or anyone else in the workforce is. They no longer have that building and that partnership they had back in the 1980s and the 1990s. Physicians and employed physicians and training of physicians these days is much more likely to train someone and employ someone to work either in the inpatient setting or the outpatient setting, but not in both. You don't have that doctor walking across the parking lot anymore to see you in a med-surg bed. Hospitalists, hospital medicine was the first one to go that direction. And that was during the 90s and the early 2000s was when we were adopting a model where if you were in the hospital, you were being seen by a doctor whose skill set, whose dedication was to seeing patients in the hospital. You weren't probably going to see your family medicine doc. Laborists, just in the last, from 2019 to today, we've seen the exact same phenomenon with OBGYNs. They will see you in the clinic, perform women's health, and take care of you in the clinic. But babies are delivered increasingly in hospitals by people who do nothing but deliver babies, and they're called laborists. So again, that shift to either or. No physician in Kittitas County that I'm aware of will admit a pediatric patient at this point. So if we have pediatricians, they are great. They provide wonderful care, but they do it in the outpatient setting. If you take your kid to the emergency department and they need to be admitted, they're probably going to be transferred because we just don't have that crossover in peds. There is some crossover with our proceduralists like surgeons and orthopedic surgeons and such. And increasingly, call is seen as the hospital's responsibility. So it's no longer the practices cover one another. More and more physicians, they want less call. Many physicians want no call at all. If they're going to be on call to the hospital, they want to be paid for it. And having call makes it incredibly difficult to recruit new physicians. So if we tell someone, we have somebody who loves Ellensburg, has a great young family, want to move them into the community, but we tell them you have 5 days, 6 days a month of acute newborn call where you have to come in and assist with the delivery, they can get the same job in Issaquah and go home from their clinic at 5 o'clock every evening. It makes it very difficult to compete. And management and governance of the hospital relies more and more now on policy and on contracts, so there's a disconnect between the physicians who practice in our hospitals and in our clinics and the governing board and administration. So what should you expect? You had, in 2020, 2019, 2024, you have a care team. You do not have a doctor. And that can be an incredible benefit to you. Your care team will include a doctor, one of those APCs that we talked about, and that team probably has multiple APCs on it. You'll have a nurse, an RN, or an LPN on the team, and medical assistants who work with them, pharmacists or pharmacy techs who work with them. And every single person on that team has their role, and we rely on them to execute within their license everything they can for the patient. And we capitalize on that. We want the MA to do what the MA can do, so the nurse can do what she can do, triaging patients or doing nurse visits, wellness visits, things like that. The APC does what they can do, and the doctor sees the complex patients and really directs the care of the team. All of your KVH records are available to the entire team. So they huddle in the morning and look at who everybody's going to see for the day. They can all see the entire record. You'll be interviewed by the MA. He may do screenings and surveys that we're required or requested to do for all our patients. They'll do a medication reconciliation, take your vitals, do a history update, and talk to you about your complaints. Your prescriptions and your supplements will be reconciled and updated, and that medication component of medicine is so incredibly important now, and I have some advice for that later on. Your doctor or APC sees all that information before they come into the room to see you. They're communicating with your MA. You should expect them to do some charting probably on a computer when they're in the room with you, and I know that's a rub and a friction for some people. Some providers don't, but most providers do at least some charting when they're in, or documentation when they're in the room. And they may come in carrying a separate phone. And the script at KVH is that they will tell you, I have a scribe on the other end of this, and someone is listening to the care and the conversation, and they're documenting in the chart so the doctor can be talking just directly with you. How you can help. Use the electronic patient portal, and if you'd like to groan now, feel free. But it's a tool. If you need help setting it up, get somebody on the team, somebody at the clinic to help set it up for you using your email address. You can go on that portal, you can request an appointment, you can get your results so you don't have to wait for a phone call, and you can leave a message for your care team. I don't know about you, but I always forget to ask about a pneumonia shot or something, so that's where I'll leave that message. And don't ever feel disrespected by seeing an APC as opposed to a doctor. You haven't been demoted. Again, you have an entire team that's taking care of you. When you call the office, please leave a message. So we have people who call and hang up and call and hang up. We have people who are in the old family healthcare building whose full-time job is answering the phone. So if we disappointed you a few years ago in how we handled the phones, give us a try again. But leave a message, we will return a phone call to you. Prioritize what you want your doctor to address. So when you call the clinic to make an appointment or use the portal, if you haven't seen your doctor in 2 or 3 years and you've gained weight and you have a sore shoulder and you have issues with your eyes, it may take longer than our typical half-hour appointment that we have. Talk through that, and they can offer you a second appointment. Prioritize those things you want to do the first time. They can offer you a second appointment. They can look out a little farther maybe and find a 1-hour appointment. But the doctor's going to want to get to the most important things that they have for you quickly. So again, prioritize what you want to talk, make yourself some notes so you make sure you hit all the things you want to. Bring all of your medications in their bottles, not with those little Monday through Sunday things that I use, and your supplements. And they'll want to see those. And the MA does a reconciliation. And you know, I was talking to the chief medical officer about this piece of the advice, and he said we see people who the physician changed the blood pressure medication and they're accidentally taking both now. Or you'll bring in, you prescribed a 90-day supply of something and they bring a bottle in 2.5 months later that has 70 pills in it. So they want to talk through, they want to do that inventory, make sure you're taking your medications correctly and as they were prescribed, because that gets really confusing. And don't forget your supplements, because they'll want to know about those as well. And if you forgot something, like I do I need a shingles shot? Use the portal, and they'll get back to you. So what happens next? There is no one out there that thinks we're going to be able to train enough doctors and nurses and techs to meet the demand. There are some off-ramps that we see patients and practices taking. Some patients and practices are simply opting out, and we have subscription-type services, and we have one here in Ellensburg, and I hear great things about Compass Direct. Is that what it's called? So you pay a subscription. They don't bill insurance at all. They don't want anything to do with insurance. There's none of that prior auth stuff. None. And they have a limited number of services. They'll tell you exactly what it is. You pay your $300. I don't know what it really is for a couple for a month. And there may be some minimal charges on top of that. So you can see the doctor, talk to the doctor. They're very responsive, but it does have a monthly fee attached to it. It's a really bad idea to go without insurance at all, because if you need higher-end diagnostics or hospital care, they can get very expensive very quickly, and they don't do anything to bill it. The other kind of practice that's out there is a concierge practice that will bill insurance, but in addition to that, they charge a monthly fee, and for that, you're guaranteed a visit within 24 hours, or the doctor will call you back. And so people are finding workarounds to this. But in the meantime, again, you have some really, really fine people still going into medicine, trying to find their way through this. Those teams are going to become more and more important. And this is not a Kittitas County phenomenon. This isn't a Washington phenomenon. And I just wanted to share it with you because this is something I've never seen before. We have a group on the east side of the state that was set up during the pandemic that gets together and shares information about capacity and who's full and what's going on. This week, due to physicians being unable or unwilling to take call coverage, the Providence system in eastern Washington will have no orthopedic trauma call. I've never heard that before. So Sacred Heart in Spokane, Cadlick, St. Mary's in Walla Walla, there is no orthopedic trauma. You can't pay the docs enough to come in and do that. So I've never heard them call that before. And the Level 1 Trauma Burn Center in Oregon has notified Harborview that they are on divert for burns. So they are at capacity and cannot take that. I don't even know what it looks like for a Level 1 trauma service to be on divert. So this is a problem we're going to have to work through. We want to be there for you in the meantime. I apologize for the frustrations. Leave a message on the phone and figure out how to get into your portal. Thank you.
Good evening. I'm Mark Larson. As I was introduced, I'm the county health officer and have been since 2006. More importantly, I've been a family physician here since 1998. So I'm one of those old people that Julie was talking about who practiced in the old system, both in private practice and then becoming a member of a system. And as of July of last year, I became a full-time hospitalist at KVH. The hospitalist system, similar to what Julie was talking about, is run by an organization called Rural Physician Group. So we're not really an employee of the hospital, but those of us that are working here are certainly still, at least in spirit, KVH employees. So I was trying to decide what I was going to talk about because a lot has happened over the last 4 years in public health. So I appreciate following Julie because a lot of the things that I'm going to talk about really go right along with what she's talking about, what's happening with medicine. So I chose to talk about trust in public health. So back when we started seeing the internet, which I was a resident and then a faculty member at the University of Kansas in the early 90s, patients started coming in with a list of things. I think I have this, I read it on the internet. We would usually roll our eyes as physicians and think, oh my gosh, I have to go through this. It's just gotten a lot more complicated. People are much more educated. They have a lot more sources of information that they can draw from. And unfortunately, not just in medicine, but in a lot of things, there's a lot of misinformation out there. So even before the pandemic, I was dealing with folks from WSU and from the CDC and other organizations talking about misinformation. And then, of course, the pandemic started and it just kind of exploded. So I'm going to talk about trust, but I'm also going to talk about what we're doing at Public Health to work on building up that trust again. Personally, I think I used most of my trust in my trust bank that I built up over 25 years. I too delivered a lot of babies in this county. I see people in this room that are my patients or have been my patients for a long time, and I'm still taking care of people in the hospital. Unlike what a lot of people at the grocery store ask me, which is, how do I like retirement? I'm not really retired. So I'm going to start with this picture, which is a picture of on the left, it's Kittitas Middle and High School, and on the right, it's the Ellensburg Christian School, to talk a little bit about trust and how we have done poorly and perhaps done well with development of trust in the community. So, and I told my boss, Chelsea Leffers, that I was going to try really hard to not use the C word. So this may be the first talk that I've given in 4 years and not use the C word. But in the beginning of the pandemic, when we were giving masking recommendations, which have changed a lot, and the data that came through have changed a lot, and that's, I think, a big part of the time that we started losing trust in public health. To get Kittitas School District to comply with mask requirements for schools, we got the state Department of Education involved, and lots of people's feelings were hurt, and people were angry, and they were forced to follow masking recommendations. I'd like to go back and have a redo. It's taken us a long time to rebuild the trust in that particular school district, and we're still helping. The school nurses have a really difficult job in all the schools, and we still at Public Health help them, but we kind of put a block in their way initially by getting these outside people to come in with hammers, and they felt like we were the people that were wielding those hammers, or I was the person wielding those hammers. So Ellensburg Christian School was a totally different approach. They too were not interested in wearing masks, but because there was not a whole lot of money that was coming from the State Department of Education for the Ellensburg Christian schools, we had a much more collaborative relationship with the Ellensburg Christian School, and they did testing at the Ellensburg Christian School. They kept people out of school that were sick. They did not wear masks at the Ellensburg Christian School. But they did a lot of other things, and we had a very collaborative relationship with them. And just recently, they had a very large outbreak of influenza at the Christian school. And who did they call? They called public health for help. They called public health to ask us what they should do. So it just shows, you know, I made a lot of mistakes through the pandemic, and but by building trust, we can continue to do the work that we are trying to do at public health. If you end up in the hospital, and I'm working as a hospitalist, you are my patient, and all the goals of what I do in the hospital is to get you well and get you out of the hospital. In public health, the community is our patient, so it's a whole different process. Oops. I want to talk about how we work with others. So this is a map of the public health emergency planning regions. We are Region 7, which is the north central region. Kelly Bacon works for the public health department, and she's in charge of emergency management. But we've also used the north central region as our region to come up with plans, with recommendations, with workarounds for things that are happening in public health. For example, we just made a recommendation for masking in healthcare. So you'll see if you come into KVH that the healthcare workers are wearing a mask when our numbers of influenza-like illness, not just influenza but other viruses. That was a recommendation from the health officers and the administrators from the North Central region. It includes Okanagan County, it includes Grant County, Chelan, Douglas, and us. We are more similar to each other than we are different. If we were coming up with recommendations for things like masking based upon the I-5 corridor, that's a whole different group of folks. That's a whole different group of population of people. And so what you'll see, a lot of the information from public health, it has all four of these public health departments, and all four, actually right now there's only 3 health officers because Dr. Wallace in Okanagan is also doing Chelan Douglas. Why are we doing that? So people realize we're not just making decisions on our own, that we are coming up with decisions based upon what's best for our region. We do a lot of, this happens to be a picture from a long time ago, but we respond to emergencies, to floods, to snow situations. You know, we end up getting people from public health, people in the community that are trapped in the snow. Public health is involved in those things. You'll hear a lot about One Health. This is another way to rebuild trust. You know, we know in general that the environment and animals and humans are all really related, but the push from those of us that do public health is really to connect those things, to work with the veterinarians, to work with the folks that are protecting the forests, to work with the folks that are doing clinical medicine, because what happens with those of us in clinical medicine also affects the animal population and in the environment. So you'll see a lot of things over the next couple of years about One Health. Central Washington University's had a large One Health conference, a 2-day conference. This is the 4th year, I think, that it's been going on. So you'll see One Health is an issue. This is a story about dog ticks, but where they look at how the environment and animals and humans interact, but you can find a whole lot of others. These were a bunch of dogs in in the Southwest that had ticks, and those ticks carried Rocky Mountain spotted fever. So the public health approach was to get flea collars on and tick collars on these dogs to not only protect the dogs but protect the humans. And it really cut down the amount of Rocky Mountain spotted fever. We currently have citizen of Kittitas County that might have brucellosis, which is a disease that comes from cattle. You know, we have a lot of cattle in the county. That's all a One Health thing, and this is, you know, some people think of public health as a regulatory agency, and we do some regulation. We, if you go out to dinner at a restaurant in the county, we have inspected those restaurants. Sometimes we shut down those restaurants, but basically, if restaurants are open in Kittitas County, you know you can safely go to eat there. Another thing that we're working on in public health and working with lots of different organizations is wildfire smoke. We were pretty lucky last year that we had a low smoke season. That's not really what's going to happen in the future, and it's not what's happened in the past. We are working with our regional partners, especially Clean Air Metau, to provide information to community members, to provide ways to build inexpensive box fans. And we know that, you know, smoke doesn't just stay in the Okanagan County. I mean, it's terrible in the Metau for sure. But we've had terrible smoke here. We've tried to help with make sure that kids are safe from a public health perspective when they're out working, and making sure that our folks at risk are protected. This is a picture of a new landfill in Adams County. This will open this year. This is just east of Washtenaw. Is that right? Mm-hmm. Yeah. So this is over 500 acres. This is the largest landfill in Washington State. It's not just regulated by public health, but we are not regulating the Adams County landfill, but public health, along with ecology and others, regulate these things because there's runoff from these things. There's definitely risk to the public. So that's going to happen this year. We were just talking about that with our regional partners today at noon. We're also working on youth suicide. So things that have happened over the last few years, suicide rates have gone up, rates of depression and anxiety in students have gone up, and we're working with the school districts to try, and with comprehensive mental health, to try to work on these things. We also have, they're not called MHPs anymore, in the ER, crisis care managers. So we have people in the ER to address these risks. Sarah Anderson is a master's nurse practitioner, or a PhD nurse practitioner student who's worked in our ER for a long time, and she's working on a program for suicide prevention with the Ellensburg School District. Hopefully we can expand that, but Sarah is one of my students that works with me in public health. Schools are trying. They don't have the resources that they need really to address the issues that are there. They have some resources, but we're trying to address them from a public health perspective. We've been doing that for a while. I remember in 2007, we had a program out at Kittitas School District to work to embed mental health professionals in the elementary school there. The other thing that all of you realize is that drug overdoses is a huge thing. You know, fentanyl was not around when I was in college. Actually, the drug of choice at that time in the late 70s was cocaine. If you have been listening to the news lately, most of the cocaine actually from South America is going to Europe, it's going to Africa, and it's actually going back to South America. You know, what we're getting here is fentanyl, and fentanyl overdoses and death have affected all of the folks in Kittitas County. All of you are going to know someone who had a son, a daughter, or a dad who has passed away from fentanyl. So for years we have had a syringe exchange program run through public health as a way to do harm reduction, as a way to reduce HIV risk, as a way to reduce hepatitis C, and it's become more and more important. We've also been working recently with folks from Comprehensive Mental Health and from Central Community Health of Central Washington to provide substance abuse treatment for those people that come into the needle exchange program, and also at the jail. You know, previously, before the pandemic, we were not, you know, people that were in the jail and our jail doesn't keep people for very long. They kind of come in, they go out, and those people were coming back onto the street and then starting using again, and a lot of those people were overdosing. So we're continuing that work at Public Health and with others in the community, again, working on the trust issue. This just kind of shows the amount of opioid overdoses. That's the top line. I don't have a whole lot of data that I'm showing today, but basically what we're seeing is synthetic opioids, and you know, I was still working at the Valley Clinic when the state started saying we needed to treat non-cancer pain better. And we were partially responsible for the number of people that were using opioids, but now the people that were using opioids and then were using heroin are now almost all drugs on the street now have fentanyl in them, and it's deadly. One pill could be deadly. So we're working on those things. I'm going to talk about vaccines just a little bit. The main reason to get vaccinated for anything is that those diseases are still here. So we have 12 cases of measles in Clark County currently. They had a big measles outbreak last year. It was about 70 cases, I think, or 70 or 80 cases. And so it's important for us to work on reminding folks that vaccine preventable diseases are still out there. Again, that's rebuilding trust. I'm going to call out what Julie was saying about what's happened in medicine. I think we've lost some, you know, if you had seen Dr. Solberg for 30 years of your life, you were going to believe what Dr. Solberg had to say. Now, maybe over the last 4 years, you might have had some questions, right? Because that's what we were all doing. We were questioning everything over the last 4 years. But it's harder when we don't have a personal physician that we've known for a long time that we can trust. But we're working on this, and we're starting to give childhood vaccines at the health department again. Why are we doing that? Because we don't have enough pediatric providers to get those folks into their providers. So we're starting to give normal childhood vaccinations again at the health department. So how are we tracking disease? I'm going to talk just a little bit about wastewater testing. So we are doing wastewater testing in Kittitas County. we are doing wastewater testing, looking at lots of different viruses. This happens to be where most of the wastewater testing is being done in the state. And as you can see, we have wastewater testing. It's in Ellensburg, so we don't have wastewater testing up in Upper County. But it does allow us to get an idea of how much disease is in the community. This talks a little bit about the different viruses. Now, you can test wastewater for everything. I mean, whatever you want to test in wastewater, you can test. It doesn't tell you where that individual test result, you can test for fentanyl, you can test for influenza, but it does give you a community-wide idea. And so it's following trends, not following individual data. But the city was very interested in doing wastewater testing. And the people that work at the wastewater treatment plant, they are really very dedicated scientists. They are so interested in the work that they do. And they were all on board with doing wastewater testing. The other place that we get data on what's happening in the community is from the hospital. We are very fortunate that we have people working in the communicable disease part of KVH, and they keep track of illnesses that come in, and we get those diseases reported to us. There's a lot of diseases that get that by law are reportable. For example, if I, as a healthcare provider in the hospital, think about testing for TB, that's reportable on suspicion. So, and our providers, I hear a lot from my coworkers, my other health officers in Region 7 that their healthcare providers are not reporting the disease to the health department, that finally, as it gets to the state, and then it comes back to the public health departments in Gillette and Douglas, for example. But I actually told one of Julie's employees that she was duplicating work, that she did not have to report those diseases to us because her providers are reporting those diseases to us. So we're very fortunate here. This actually talks about syndromic surveillance, so you might hear some about that. That's data that's gathered from ER visits, it's gathered from urgent cares and those type of things, which gives us, similar to wastewater testing, it gives us an idea of what's happening in the community and allows us to help people to protect themselves. So we're super fortunate to have that, and KVH has been a really good partner. They've stolen a lot of our employees over the years, and so there's a lot of people that used to work at public health and now are embedded at the hospital, which is really good for us because they understand public health. So I consider that a win for me as the health officer. And then this is just going to dovetail into Robin Reed. Robin Reed used to be my boss at the health department, and I consider her a good friend. The CHA CHIP, so Community Health Assessment, and the Community Health Improvement Plan is, I'm going to take a step back. So in Washington State, public health is local public health. So what's important in Kittitas County is what we work on. The state does have us work on certain things. We work on TB, we work on opioid overdoses, but basically the diseases, the illnesses, the problems that we work on, most of you kind of remember the problem we had with exempt wells, for example, in Upper County. Public health was involved in that because it was a water thing, and Paul Jewell felt like we in public health understood water better than anyone else that would work for the county. So we were given the exempt well thing. But the CHA and the CHIP are basically what's important to the community, and that tells us at public health what we need to work on. So thank you for listening to this. I did get through a whole talk without using the C word, and I appreciate that. Thank you. What's the C word? I can say it now because I'm done talking COVID. All I've talked about for the last 3.5 years has been COVID. So. Yeah.
So thank you so much for having me here today. My name is Robin Reed. I'm the Executive Director of the Kittitas County Health Network. And I'm going to go through my slides pretty quickly. I'm going to try to focus on the most important stuff and really dovetail into what Julie talked about and what Dr. Larson talked about. The Kittitas County Health Network is a collaborative of about 60 different organizations in the community. And I'm going to talk a little bit more about who those organizations are. I'm going to skip a couple of slides here. So the health network is based on what's called a collective impact model. And what that means is that the organizations that participate in the network really come together and are driving change toward a common agenda. So we're all working together to improve the health of the population here in Kittitas County. We use shared measurement, so we have measures that we use to show that we're making progress. Mutually reinforcing activities, so organizations coordinate their activities to make a difference in certain areas of the community. We have a system of continuous communication and then a backbone organization. So the Health Network is a 501c3 nonprofit, and we serve as the backbone organization for this collaboration of organizations in the community. So this isn't all 60, but it gives you an idea of the breadth of organizations that participate in the network, ranging from healthcare, to public health, to first response, law enforcement, education, long-term care, housing and social services. So we really have a true cross-sector collaboration here in this community. So how we got started, back in 2015, some of you may remember the Royal Vista nursing home. When that nursing home closed down, a group of people got together from some of the different organizations, care coordinators, social workers, first responders, to really make sure that nobody was falling through the cracks when that happened. And what they found was they had a lot in common, and really by coordinating services, they could really help people a lot more. One of the big things that they found was that they could prevent usage of emergency services for non-emergent reasons. So they found that a lot of people were using emergency services for things that could be prevented. And they started working with those people and their families to get them what they need so they didn't have to rely on 911 quite as much. In 2017 was when we got our first major fund source and really established the 501c3. So the collaboration was going before that on an informal basis. The A-team was this group of people who were meeting on a weekly basis to coordinate care for people with complex health and social needs. We received some funding in 2017, established a board of directors and a leadership council. And then in 2018, we adopted the Community Health Improvement Plan as the work of the network moving forward. And I'll talk a little bit more about that in a minute. In 2019 was when the first staff person was hired. That was me. And that was, 5 years ago. So it's hard to believe that sometimes. And then we proceeded to get several different fund sources through the federal government and agency called Health Resources and Services Administration. So we got a grant to support the work of the A-team and care coordination. We also got a couple major fund sources to do work around substance use disorder and behavioral health, mental health. So the vision of the Kittitas County Health Network is that all people in our county are supported in achieving health and well-being. And we do this through our cross-sector collaboration, through systems integration, breaking down silos between different sectors, and really focusing on the health of the community as a whole. So some of our accomplishments, here's where I'm going to spend a little bit of time because I'm really proud of some of the things that this network has done. And these are things that wouldn't have happened or likely wouldn't have happened otherwise in our community. So through the care coordination program, we've served over 300 patients in helping them get connected to the services that they need. We have about 25 different organizations who actively participate in those efforts on a weekly basis. We have a public-private partnership with a local daycare, Happy Feet Academy, Kittitas Valley Healthcare, Kittitas County, to expand access to childcare in the community. Happy Feet is opening a new childcare facility, adding 112 childcare spots to our community, and that's out of 700. So it's a pretty significant increase for our community. We also worked with the county to make some code changes to allow more childcare businesses to open in the county areas. One of the benefits of having a rural health network is that we can identify gaps in the community and really work together to fill those gaps. So during the pandemic, one of the gaps that was identified was that our uptake of vaccine for our Latino community was really, really low. And there was a lot of misunderstanding, a lot of misinformation, and a lot of lack of information getting to that population. And so through a partnership with the Public Health Department, we were able to hire 2 community health workers that work with that community to get vaccinated. And that work has expanded to beyond just COVID vaccines, but also getting access to other services in the community. We've worked with the Kittitas County Jail, Kittitas Valley Healthcare, Community Health of Central Washington, Comprehensive Healthcare, Merit Resource Services, all to expand services for substance use disorder prevention in the Kittitas County Jail, which then reduces recidivism and helps get people connected to services once they're released. We've done a lot of presentations around substance use disorder, just trying to increase knowledge about what that means and reduce stigma, which then increases access to treatment and services. We've distributed over 500 naloxone kits, so this is really important in overdose prevention, opioid overdose. We've increased medication take-back locations from 3 to 10. So 5 years ago when we first started getting some fund sources, there was 3 places in the community where you could return your unused prescription medications, and there's now 10. There's 1 in Kittitas, 6 in Ellensburg, and 3 up in Cleveland. And then we recently, another gap that was filled, we recently became the sponsor for the SHIBA program. SHIBA stands for State Health Insurance Benefits Advisors Program. And it's a volunteer-run program that helps people with Medicare-related issues. And we've helped 250 people since July, since we became the sponsor in July. So again, a really important gap that's been filled. So a couple others, we have also worked with the Public Health Department in enrolling children in developmental disability services. They ran some data and discovered that Kittitas County was at the bottom of the list for all 39 counties for enrollment rates in developmental disability services for children. And so again, through our community health worker program, we've been able to work with families and help spread awareness about what services are available to them. The Kittitas County Resource Guide, we really heard strongly from our network members that we needed to bring a resource guide back to the county. It's a project that different organizations had taken on at different times and then let go of, and it's pretty resource intense, no pun intended. So we now have the resource guide, and it's updated on our website at least on a quarterly basis. We also print out copies for agencies to use, and it's very, very comprehensive. I talked about the SHIBA program, and then most recently we collaborated with Community Health, the Recovery Community Organization, the Kittitas County Jail. I think I might be missing one other partner on a coat drive for the community. And I know a couple weeks ago when I asked, we distributed over 100 coats. So I think that by now that's probably gone up quite a bit. So Dr. Larson talked about the Community Health Improvement Plan. The Community Health Improvement Plan is informed by a really comprehensive community health assessment that's facilitated by the Public Health Department, and really identifies what are those key priorities in the community, what's important to the community that we focus on. And then the collaboration of the Kittitas County Health Network really works on implementing the strategies in that plan. So the first area, first priority area is access to health care. The strategies are increasing care coordination services, so that's going back to when I talked about the A-team, so really trying to expand those services. Workforce is a big issue, and you heard Julie talk about that. And so, really just figuring out, what's being done around workforce, where more support's needed, what can we as a collaboration do to help. And then addressing barriers to accessing healthcare through closed loop referrals, warm handoffs. So this is the idea that instead of just telling somebody, hey, you need help, you need to go to Hope Source, or you need this service, you just need to go there. It's actually making a phone call for them, or making sure that, do you have any barriers to getting there? Do you have transportation? Are you able to make those appointments? How can we help you get there? And that's called a warm handoff. Behavioral health, so substance use disorder and mental health, this is the second priority. And what we're doing around this is really working to reduce stigma and increase awareness of the resources that are available. And then increase services in school settings and other youth-serving organizations. Children, youth, and families was the third priority that was identified, and we're really working here to increase access to recreation activities, so healthy, safe activities for families and their children. Improving childcare and other prevention resources such as youth mentoring. Increasing communication and adding opportunities for communication between community partners and families to really understand what are their needs, what are the needs of their kids and the youth in the community. And then increase mental health services in schools. One of the things that the network has been able to do is we received a $2 million grant through the federal government, and part of that grant is paying for 2 full-time school-based therapists that split their time across the county, so we were able to increase those services. So what's next for the Kittitas County Health Network? We're working on implementing the Community Health Improvement Plan. This is a new Community Health Improvement Plan. They run on a 5-year cycle, and so we're just starting the beginning of the next 5 years. Sustainability. So the network's been around now for several years. We are still primarily grant funded. And as most of you know, grants usually have an end date. And so we're really looking to see, how can we ensure that this collaboration and the backbone organization keeps going and keeps providing that benefit to the community. And then we're also just looking at what are the outcomes that result from this collaboration. And one of the things that we're really seeing is a reduction on usage of emergency services and a reduced burden on municipal services such as law enforcement, parks, et cetera. So this is my last slide. How can you get involved? We do have a website. You can use the QR code if you're interested in going to it right now, but it's healthierkittitas.org. We do have a monthly newsletter where you can stay up to date on what's happening both among our partner organizations and in the network in general. We have work groups around each of the different priorities, and those are people from the different agencies as well as community members that come together and really work on those different strategies that I just talked about. So you're welcome to contact me with any questions or if you are interested in getting involved. So thank you very much.
So we'll take a few minutes. We're running a little long, but I think it's okay if we take 5 or 10 minutes of questions if the audience has any. Please ask it loudly so we can repeat it into the microphone. Does anyone have any questions? Yes, Allison?
This is probably for Robin, but I wondered what Central has to do with the health network. Like, do you work together with Central?
Sure. So the question is, how does Central Washington University work with the network? So they are involved. We have people from around the university that participate in our leadership council and our different work groups. They represent and just really bring the voice of Central Washington University to the table. Yes?
I've noticed that there's been no reference to any religious or church organization there. I'm a very active member of the local congregation. Interestingly to me, our church secretary at one time was employed by Hope Source. You see people coming in all the time, requesting monetary, but also other kinds of And we also organize small groups within the larger congregation for mutual support. It just occurred to me that you're missing a big resource by not involving churches, because they have access to a great deal of knowledge of people who have no ability or inclination to otherwise contact any one of these healthcare affiliated organizations. They would, but they don't know about them. And I'm thinking that contacting churches just to say, give them copies of your guides and a 15-minute presentation like we just did now about what is you do and how to involve people in them and make the world be helpful.
Yeah, so just to kind of repeat, asking about the involvement of churches, and that is definitely something that we've prioritized this year. We do have somebody, and I can't remember off the top of my head what church the gentleman is from, but participating in one of our work groups this year. We received some funds from the Suncadia Community Foundation to really do some promotion about our services in Upper Kittitas County. So we've done several presentations with churches in Upper Kittitas County and plan to do more here in Ellensburg. We are also working on a partnership with Swiftwater Church in Cle Elum to provide volunteer services to our care coordination clients. So we're working on it. And you're absolutely right, huge resource for our community.
Yeah, I'd like to add to that. The church communities in Kittitas County were my best partners during the COVID-19 pandemic. They stepped up to the plate. They got information out to their congregants. We met on a weekly basis. We have not been doing very much with them since things have slowed down, but it's a good reminder to re-engage with them. But they were amazing, really.
Yes?
So the measles that we're hearing more about in the news lately, the outbreaks that are happening. So for those of us who were vaccinated many moons ago, do we consider getting a new vaccine, or are we vaccination? Are we good for life, or what's your thoughts on that?
It depends on your date of birth, but most of us are who've gotten vaccinated as children are fully immune. What we're seeing really is the decrease of uptake in all kinds of vaccines, but certainly MMR vaccine, and the populations that that occurs in is where most of those outbreaks are happening. The one in Clark County had to do with, actually, interestingly, Ukrainian community. So, and as we have more immigrant population, it's become a much bigger problem. It's hard, as Liz Whitaker would know, to try to interpret vaccine records from other countries. It's really difficult. But for most of us that have gotten vaccinated as a kid, we're fine.
Liz?
Or have you?
You had a question?
I was wondering, the Health Network identified mental health support as an issue. What about for older people? I've heard some people say that, once you hit 65 and you're on Medicare, you can't get a counselor. You can't get your insurance won't pay for a counselor anymore. I don't even know if that's true, but have you identified that as an issue at all? And is there anything you want to know about that?
I have not, but I'm probably not the right person to ask. My care coordinators might know more about that, but that is not something specifically that I've heard.
The question was around whether mental health care was available to older residents under their Medicare coverage.
Yeah, and I don't know the answer to that, but I can tell you. What? Yeah, that a supplement.
Randy, but then
Yeah.
you haven't notified.
One of the big groups in our county that have had difficulties have been veterans. So the health department has taken over the Veterans Coalition, which was a volunteer organization. So it's now, I mean, it's still at the health department, which it's been for a long time, but it's a whole different deal run by Candy Blackford is the lead of that, and we're addressing that. But it's a really good question about those of us that are older than 65, right?
A friend of mine just called me in a panic, and she just had her 65th birthday, and she said, I don't think I can go to my counselor anymore, and I need to. I was like, I don't know what to tell you. Yeah.
Tish.
I just wonder if county health departments are thinking about developing plans, negative review, but if there is a future, another pandemic, or is that something that health officers are doing, or?
Yeah, it's
Excuse me, let me repeat.
Oh, yes.
The question is the health department working out plans for a future pandemic?
the answer is yes. And so in 2006, when I became the health officer, we had a health officer from Seattle. She was a pediatrician, and they asked me to fill in just in case we had a situation like we ended up having, and she couldn't get over here. And then she resigned before I went over to interview for the position, and that's how I became the health officer. We will see another pandemic in my lifetime. I probably won't be working at the health department, hopefully by that time. I think one pandemic is enough for me. But we are working on that. It kind of falls under emergency management. So Kelly Bacon is dealing with our emergency management things. We as a society are very short-sighted. So it's really hard to keep it in the public's eye, but there's a lot of work that's being done. The money is a difficult problem. I mean, I think President Trump did a great job in regards to the vaccine and getting that going, but most of the time those things happen like that happened after the horse had already left the barn. So we locally are working on it, the state's working on it, the feds are working on it. The World Health Organization knows it's going to happen, and we are encouraging vaccination when people can vaccinate. The fact that we all travel, and it takes one person from one country to all of a sudden have a problem here. But yeah, it's on people's radar. But this year, it's probably not going to be on very many people's radar because of the election.
I have one question to wrap this up. It's actually a two-parter. Is the CHA posted on the website anywhere?
I'm not sure. I think not yet, but I think it's very close to being published.
And then the companion is the Community Health Improvement Plan. Is that posted anywhere people can
The
get it?
same. I think it'll be posted very soon by
And then
the
the
health department.
third part of that question is, what are the metrics that will be used to determine if you hit those strategies or those priorities, that you made the improvement? I mean, are you actually, is there objective data that's involved in this, or is it just going back and doing a repeat CHA?
Yeah, that's a difficult question to answer because, in public health, or when you're working on broad community health measures, it's hard to say that because we did this, we affected, this particular measure exactly. But we do, by doing the community health assessment again, kind of pay attention to trends that way. So we look at that.
Great.
One of the things we haven't really talked about is the 1/10 of 1% for mental, the 1/10 of 1% tax for mental health. Those funds have just been awarded for the first time. The group that is looking at those groups that are asking for funding are definitely asking for measurable metrics, because that particular tax has a sundown clause. So if we can't show that what we've been doing has had a benefit on, for example, emergency room visits for mental health or whatever it happens to be, then it's quite possible that that funding will go away. So that work has been is very aggressively being looked at. Work on the number of people that are getting started on substance abuse treatment while still in jail. That's a metric that we're looking at. The number of overdoses. We've always looked at syringes exchanged, but now that people are using heroin less and fentanyl more, we're actually exchanging less needles. But there's certainly data out there that we're looking at.
And I would just say on the 0.1%, we are being funded for 2 crisis care managers in the emergency department. We admit or discharge about 95%, and ER visits in Kittitas County are up over 20% year over year. We admit or discharge home about 95% of those. But the single largest group of people that we have to transport are mental health patients, behavioral health patients. And those crisis care managers work 12, 14 hours a day to find placement, adolescent, adult, senior placement, the care that these patients need, and make sure that they get there. So it has been incredibly valuable to KBH and to the emergency department in particular.
One last question in the back.
Hi, I just want to have a shout out to you, Robin. I'm so glad for you and Dr. Larson as well. But my question is for Julie. There's another C word that nobody wants to talk about, and that's corruption. And I just hypothetically, Julie, if you knew of 2 of your senior managers who are abusing employees and violating state and federal regulations, what would a good CEO, what should a good CEO do about that?
Well, I'd certainly want to hear about it so that we could deal with it.
Thank you. I want to thank our panelists for being here tonight and donating their evening to this event. And I also want to thank Ellensburg Public Library for being a co-sponsor of this event. And thank you all for coming.